Thank you for the opportunity to present my research today. Today I'll be talking about an objective degenerative spondylolisthesis instability classification system to reduce variation in surgical treatment, presenting on behalf of the authors listed here from various Canadian institutions. We have no disclosures. This is a talk about degenerative lumbar spondylolisthesis, or the forward slippage of one vertebrae on another. This talk pertains to instability and how surgeons define whether spondylolisthesis is stable or unstable. This is currently done subjectively, and it can lead to the overuse of invasive surgery. So how do we reduce variation in surgical treatment? The Qualitative Degenerative Lumbar Spondylolisthesis Instability Classification System, or DSIC, has been developed. In this system, surgeons consider dozens of instability parameters, both clinical and radiographic. Here's an example. This DSIC system classifies patients as either stable, potentially unstable, or unstable. And based on which of the three types the surgeon assigns, after weighing the different parameters, it recommends a procedure. So, for example, a stable patient might be recommended a decompression decompression alone, whereas a type 3, where a patient is unstable, they might be recommended the most maximally invasive option that would be available, which would be a decompression posterior instrumented fusion with an interbody device. You can easily imagine how, regardless of the clinical and radiographic parameters, surgeons can overestimate instability and thus offer more invasive surgery if they wish. Our first objective for this study was to quantify the qualitative system, thus deriving an objective scoring tool. So we used instability parameters that had been previously selected by a prior systematic review. The evidence quality was assigned to all of these different parameters. There are more. The point here is not to memorize them all, it's just to show that we reviewed many of them. We excluded parameters that had very low quality evidence, and we included parameters that had at least low quality evidence or better supporting, and assigned a point value based on the level of evidence. Here you can see the 5-point score that remained. Faceta fusion on MRI, low back pain greater than 5 out of 10, disc height greater than 6.5 on the radiograph, translation of greater than 4 millimeters on the lateral radiograph, and a disc angle that was kyphotic or neutral on the flexion radiograph. With our score in hand, we then wanted to calculate quantitative DSIC scores for real patients, actual patients, and as such, we conducted a multi-centered prospective cohort study across the Canadian Spine Outcomes Research Network, or CSORN. So this was various Canadian institutions and participating fellowship-trained spine surgeons. We included patients with degenerative lumbar spondylolisthesis, and we excluded patients that had static stenosis or a slip secondary to infection, trauma, or pars defects. Surgeons assigned a DSIC type qualitatively for all of the patients in the study, and were able to actually offer whatever surgery they pleased. So, for example, they could say a patient was type 1 or was stable, but they could offer the most maximally invasive procedure if they wished. 400 patients were eligible and 76% were included, and here you can see the breakdown of the different points that were assigned for each of the different parameters for the patients in our study. So you can see here that 50% almost of patients receive a point for faceta fusion, for example, whereas 28% received a point for disc angle. We then summed the points, as you can see here, and then this allowed us to select the recommended surgical procedure based on the objective scoring tool. Next, we wanted to compare our objective scores to those that were assigned by the surgeons, so objective compared to those qualitatively assigned scores. Here you can see this. So on the left in the rows, you can see the qualitative DSIC type assigned by the surgeon, and in the columns on the right, the quantitative type that was objectively determined by our tool. And the red boxes indicate cases where surgeons overestimated instability. They assigned a higher DSIC type than our tool. So to summarize this data, surgeons overestimated instability in 42% of cases. Lastly, we wanted to determine the percent of patients receiving more invasive surgery than was objectively warranted. Here's the breakdown of the actual procedure patients received, and you can see that 56% of patients actually received the most invasive surgical option. So we compared the actual procedure that patients received to the one that was suggested by our objective tool. Once again, to summarize this information, 57% of patients received more invasive surgery than was objectively warranted. The limitations here This is a study that was based on low-quality evidence, but we must make decisions, and this was the best available evidence. And there's no cutoff in the literature as to what constitutes an instability for low back pain, so we arbitrarily selected a greater than 5 out of 10 threshold. To conclude, the take-home here is that surgeons categorize greater degrees of instability than objectively justified using our tool, and 57% received more invasive surgery than objectively warranted in a prospective study. Thank you.